next speaker is Dr. Bonnie Brown. She is she's one of our alums. She graduated after being chief resident here in 2017. She is currently an assistant professor for both the departments of emergency and internal medicine at Mount Sinai Morningside and Mount Sinai West. And her interests currently include patient safety, quality improvement, and she currently serves as the senior medical director for observation medicine at both Mount Sinai campuses. So everybody is all settled. You can take it over, Dr. Brown.
All right, thank you, everyone. I am really excited to be here today. To be back virtually, at least. And thank you, Jimmy, for inviting me back. So today, I'm going to talk to you about observation medicine, the what, why, who, and how. Okay. So the outline today, we'll first go through the purpose and background information. Why did observation medicine come to be in the first place? A little bit about finances, what patients are appropriate for observation and who is not. And then I'll talk a little bit about the metrics that I use to measure if our observation units are functioning optimally. And I'll tell you a little bit about what my role is as the medical director. All right. So what is observation medicine? CMS has a very long and wordy definition, but what it really means is observation is a place for patients to go for further testing and or treatment while the determination is made about the necessity of further inpatient workup or treatment, or if they're safe to discharge home. So RE2, that is the Rapid Evaluation and Treatment Unit. That is what my observation units are called. You might work somewhere where they're called CDU, or clinical decision units, or chest pain units, or short stay units, or just the OBS unit, but it all is the same thing for observation status. So as I said, observation is a status. The patients are not admitted to the hospital. They are outpatient. So these patients, you don't admit someone to observation, you place them in observation status. So it can be described as internal medicine at an emergency medicine pace, which is our observation units are staffed by hospitalists, and some of them really don't like that pace, and some of them are more okay with it. So in the emergency room, as you know, we work in more minutes, maybe to hours, and on the floors, it's always days. And then in the observation unit is that in between, more in hours, and specifically no more than 24 hours ideally. So who do you need on your team to make sure that you have a successful observation unit? So you need your providers. So our units are staffed by nurse practitioners or physician assistants along with an attending. I know that you guys also work in the observation unit there at Kings County. But across the board, it's going to be different depending on different hospitals' needs. We work very closely with our case management department. We have a dedicated observation case manager who helps to review all the cases that come into observation and help to make sure that the dispositions are correct. And in the emergency room, they're working really closely with our ED providers to talk to them about what patients do you think you're going to be keeping in the hospital? Do they meet admission criteria? Maybe observation's a better choice. Social work is very critical. We do get quite a few patients, especially more so at Morningside, where maybe they just aren't quite safe discharges. You're worried about the support they have at home, those kind of things. Observation is a great place for those patients to go to optimize them, to get them home safely, as opposed to admitting them to the hospital. So social work plays a huge role. The nursing staff needs to really understand what observation medicine is and what your goals are. So really having dedicated staff is pretty important for that, from their discipline as well. And then hospital administration, it comes from the top down. So we need to make sure that if the administration supports the observation unit, its purposes, then everyone down the line will also do so. So you really need buy-in from all the other departments. So I work really closely with cardiology because our top diagnoses that we see in the observation unit are chest pain, CHF, syncope, those kind of things. So we work together very, very closely. You need the radiology department to remember your time constraints. So our patients are prioritized almost ahead of all other patients in the hospital besides the emergency room, along with the echo lab, stress testing, those kind of things. So our patients are always prioritized so we can meet our time constraints. pretty much you need buy-in from any department that you're working with the observation unit. All right, so let's talk a little bit about what kind of observation units you might see in your future jobs. So the first differentiating factor is there a specific space for these patients? Is there a dedicated unit? We have dedicated units up as a portion of our telemetry floors at both of my institutions. And so it's separate space. You walk up, it says RE2, and those beds are observation. I know that at Kings County, you have the specific unit where the patients go to. But what you might also see is something called a scatter bed model or a virtual observation unit. And these patients are placed in the hospital amongst other inpatients. So they are in observation status, but in an inpatient bed. And so this is not as desirable because of the reasons I mentioned before. Your whole team really needs to understand the point of the observation. And if a nurse or a social worker is caring for inpatients at the same time as they are the observation patients, they might not be prioritizing them in the way that they should be. The second differentiating factor is, are your units driven by protocols and pathways? So what does that mean? If a patient comes in with chest pain, do you have a specific pathway for what you're going to do for those patients? The units that are protocol driven and have pathways and have a dedicated space are the most optimal and likely to succeed. So that being said, I can't come here today and tell you this is the best way to run an observation unit. Every hospital is going to have different needs. There is no one size fits all. It's going to be based on what the priorities are for your hospital, and that can even change over time. Is the priority throughput and ED crowding, or is it mainly financial and based on the payer mix that you see? So our needs have changed significantly over the past year. The observation staff has been redeployed to do inpatient service, and we had to be really creative with how we were using the observation unit. So this isn't one size fits all. You're going to see different things at different hospitals, and that's okay. And that's one of the reasons it's there. So I wanted to show you a little bit about talk about what these protocol-driven units are. So I like to call them diagnostic or care pathways. And these are specific to the diagnosis that the patient is or chief complaint more so that the patient's coming in with. So chest pain, maybe they have a mild to moderate CHF exacerbation. They syncopized. It's an asthmatic that's not, requiring supplemental oxygen. So based on the specific chief complaint that they come in with, that you have a specific diagnostic pathway that they're going to go down. So what I have been working on, because I wear many hats and I work in the emergency department and very closely with the ED administration, is working on pathways that start when the patient comes in the door to the emergency room. So a patient comes in with chest pain, they're going down the same path. And so from the ER to the observation unit or admission or dispo. So ideally you would have these pathways that are following the patient so that every patient is getting good, high quality, evidence-based care. So every once in a while, I have to develop new pathways because we've just found a need. So I wanted to walk you guys through an example of the most recent pathway that we developed. We identified a deficiency because in my prior role as director of quality for the ER, I used to review all the bounce backs to the emergency department. And we were finding that patients that presented to the emergency department with acute onset dizziness, we had a handful that bounced back and were diagnosed at that time with a posterior circulation stroke. So because of this deficiency that we identified, we said we need to kind of streamline care here across the board. We don't want every dizzy patient coming into the hospital to the observation unit, and we don't want to send all of them home. So we need to really have a diagnostic pathway to help the providers provide the best care. So when you're developing a pathway, you can think of the 4 Ds. The first is discovery, doing your background research. What evidence is out there? What pathways already exist? And then going through that information and saying what might or might not work for my institution and my patients. The next step is the design. So this is the pathway development, I think the fun part. And you're working with the key stakeholders. So for this example, I worked very closely with our neurology and stroke colleagues, along with some of the ED administration. And I pretty much represent the internal medicine side because our observation units live under internal medicine. Then the next step is the do. It's the education and implementation stage. So you go back and you teach all of the providers from neurology and emergency and also internal medicine that are going to be caring for these patients to understand what the standard pathway is and the evidence behind it and why we're doing it. And then the last step is the data. You go back and you say what's working, what's not working, and then you go back and you improve. So for this pathway, we finished the design and we are working on the next step, which is due. So we'll see how that goes. All right. So let's switch gears and talk a little bit about why we have observation medicine to begin with. And it all comes down to money, really. That's why they were developed in the first place. So CMS in 2014 came out with the 2-midnight policy, which says that inpatient payment is generally appropriate if the physician expects that the patient's stay is going to be at least 2 midnights in the hospital. Otherwise, outpatient payment would generally be appropriate. And observation, as I said, is outpatient. So this was implemented in 2014 and then updated again in 2016. But why did they come up with it in the first place? The main reason is they came back and said, we're paying the same amount for these short stay patients, short admissions, as we are for the patients staying there longer. And these are improper payments. These patients should have been observation. And the second reason is these patients that are outpatient or in observation for long periods of time can have adverse financial consequences mainly, which I'll talk to more in a couple of slides. And then the third reason is they just really wanted to get rid of these inconsistencies across the board and streamline what's happening at all the hospitals across the nation. So in 2016, they said, you know what, this might, 2 midnights doesn't fit everyone. We need to change. We need to just add in a couple of circumstances where you should pay for an inpatient stay, even if it's less than 2 midnights. So certain inpatient only procedures. So say a patient comes in with acute cholecystitis, they're young and healthy, they go to have their surgery maybe later that evening, the next day they're feeling great, and they go home. That still meets inpatient criteria and will be paid as an admission. If you intubate them in the emergency room, you're not going to be placing them in observation, so that will be paid as inpatient. And obviously, unforeseen circumstances, a patient passes away or they leave AMA, then that still will be paid as inpatient. And the fourth one's important as well from an observation standpoint and understanding how it works, is if a patient is in the hospital for longer than 2 midnights, including their observation stay, then that whole stay will bundle into an inpatient stay. So for example, if a patient comes into the hospital Sunday morning, they have an asthma exacerbation and you decide that they're not quite ready to go home. So you place them in observation. The next day, about 24 hours later, you're like, they're just not quite there yet. So you decide to admit them to the hospital. The next evening, they feel great and they are discharged. They've now been in the hospital for 2 midnights. That entire stay is going to roll and be bundled into one inpatient stay. So that first observation midnight is no longer observation. It's bundled into the inpatient. So that will count as a full inpatient stay as well. So bear with me, a few slides on insurance and Medicare, but it is really important to understand just everything else. It all goes to pull it all together. So Medicare Part A is the inpatient hospital care and services, amongst other things. Medicare Part B is outpatient services, including observation. And then this slide, and I think this is why I wanted to even talk about any of this, is because I think one of the most common questions we get working in the emergency room is, well, isn't this going to cost me more? Or what is the cost to me as a patient? And so if a patient's admitted to the hospital is going to bill Medicare based on the patient's DRG, which is a diagnosis code. This is a bundled payment. And the patients, which is the beneficiary, will have about, I think this is last year's, is about a $1,500 annual deductible. For outpatient, including observation, Medicare pays 80% per service, so they pay 80% of their bill, and the patient will pay 20%. So let's look at what some of those numbers might look like. So in this slide, what it's showing you is a couple of different diagnoses and what the costs to Medicare are and what the costs are to the patient. So let's go with chest pain. That's one of the more common observation diagnoses. And if a patient is admitted to the hospital and has a short stay, the hospital is going to bill Medicare just under $4,000. If they are put in observation, they're going to bill about $1,300. So roughly a third there. The cost to the patient for that diagnosis is about $1,000 if they're admitted with a short stay, versus about $350 if they're in the observation unit. So you can see that's a huge difference in cost to the patient. So the same patient, though, if you admit them to the hospital, they come in with chest pain, maybe cardiology is consulted, and they decide we are going to take this patient to the cath lab, and they end up inserting a stent. So this patient, if you put them in and you admit them to the hospital, even if it's a short stay and they go home in less than 2 midnights, they're going to have, Medicare will be billed about $13,000. If they're in observation, it's about $8,000. So the hospital will be paid for about $5,000 less. But more importantly, this cost to the patient, you can see this discrepancy here. If they're admitted to the hospital, they're going to get about a $1,000 bill. But if they're in observation, they're going to get about $1,700 bill. And the reason for that is, like I said, they're getting billed 20% of everything done, and that includes the catheterization and stent placement. So it's not financially beneficial to the patient when they have this diagnosis and this procedure. They meet admission criteria at that point. So it's better to admit them to the hospital, because the hospital will be paid appropriately and it will be more financially beneficial to the patient. And so what you can see here also, just to point out the other diagnoses, if they have syncope, the cost to the patient's about a third that as inpatient, and same thing with digestive disorders, which covers things like maybe mild gastroparesis or cannabinoid hyperemesis or something along those lines. So the cost to the patient is almost across the board better if they're in the observation, or less if they're in the observation unit. But I'm going to tell you about a couple, it's important to remember that the inappropriate patients that end up in observation might end up paying more. So there was a report back in 2014, from the Office of the Inspector General that came out and looked at all Medicare beneficiaries, and they wanted to look at this. They're like, is it better? Are the patients paying more or less out of pocket when we put them in observation? And it found that about 94% of patients that go to the observation unit versus a short inpatient stay have lower cost. So about 6% of them might have higher costs. So those are probably the patients that are in there for a longer period of time, or are getting procedures that are more costly. And then what about commercial insurance? So the American Journal of Emergency Medicine did a retrospective analysis over a 7-year period, and they found that the cost to the patient was about 33% less across the board. So those are, 2 studies that you can look at and maybe can, quote when patients ask you about this. All right, so just wanted to show you some nationwide trends about admissions from the emergency department. So the top line here is the blue line is inpatient hospitalizations from the emergency room. And you can just see that over time, it starts in 2008, over time it has slowly decreased, while the red line, which is observation stays, has slowly increased across the board. This slide just shows the top 2 graphs are the out-of-pocket costs to the patient. Just one more picture to elaborate that the cost to the patient out of pocket, the blue line is the inpatient hospitalization. It's always more for the inpatient hospitalization compared to the observation across the board. And the bottom is just the overall healthcare cost. It's much higher for inpatient stays. So let's talk about just the overall pros and cons of observation medicine. So there have been a lot of studies, mainly over the past, I'd say 10 to 15 years. Usually what the studies will look like is looking at an ED observation unit, syncope, for patients with syncope, observation unit versus inpatient, or chest pain, or certain diagnoses. So that's kind of when you're Googling this and looking up for what kind of data is out there, it's usually based on specific diagnoses. But what they found across the board for most of these diagnoses is that observation units, the patients have a decreased length of stay. There is an overall decreased cost to the healthcare system. It helps to decrease avoidable admissions to the hospital. You improve your resource utilization, which is generally in the units that are using these diagnostic pathways, like I mentioned before. Increase patient satisfaction. They're getting the same level of care, if not better, faster. So they like that. And it can improve the ED throughput and this crowding. And as you guys know, there's a huge ED crowding issue. So this can also help with that issue. And then the biggest con, I think, is that if you're not using it, you're not selecting the right patients, this overutilization can lead to these increased costs to the patients if they have this prolonged length of stay and certain diagnoses. The other side of it is you have to think about the financial implications for the hospital. So the cons, if you're putting patients in the observation unit that meet admission criteria, the hospital is not getting compensated appropriately. All right. I did leave a lot of time at the end for questions as well. So if you have anything, just kind of jot it down, and at the end we'll go through everything there. So let's talk about what are the most appropriate patients for the observation unit. So the ideal patient is one that has a specific question. This patient that has asthma exacerbation, are they going to be able to go home safely? Or this patient that syncopized, I want to watch their telemetry and for 24 hours and see if there's an arrhythmia. There has to be a specific question for this. So things like an undifferentiated altered mental status might not be ideal for an observation unit. Patients that you expect them to go home within the next 24 hours. So for all the reasons that I mentioned earlier, they should have a relatively low severity of illness and be low maintenance and not require any higher level of care. The nursing staffing ratios for observation units is not as robust as inpatient units, so you have to consider that based on your institutional needs. We exclude patients that are on one-to-one because we don't have patient care techs. We don't have people to do one-to-ones. So we exclude patients that are acutely intoxicated or maybe severe behavioral disturbances for that reason. And then the patient with multiple acute conditions or are too complex might want to be excluded just because they're unlikely to go home in 24 hours. So maybe you've got a significant AKI with CHF. The likelihood that both of those issues are going to improve by the next day is quite low. So those are patients that probably should be admitted to the hospital. So just wanted to show you what our exclusion criteria look like. This is a general box that I have at the top. I'm not going to go through it in detail, but it's pretty much just general reminders for the ED staff and case management. If they are hemodynamically unstable or septic, they're not going to go to the observation unit. And just reminders for certain things. If you expect the patient's going to need a certain procedure, like an endoscopy, they have to be admitted to the hospital for the financial reasons like I mentioned earlier. Or if they have a significant metabolic derangement, then you're not going to expect that to be better in 24 hours. If they're still on BiPAP or on supplemental oxygen, they're probably not going to be going home the next day. So I want to just go through a couple of the boxes that we have here. I have the chat open in another here, and someone asked, does this include IR procedures? So that's going to depend on your institution. So we do accept patients in the observation unit for simple procedures, like someone getting IV antibiotics at home and their PICC line fell out, or their nephrostomy tube just needs replacement. We will take them in the observation unit because it just makes more sense from a time and financial standpoint for the more simple procedures. If it's someone though that has, maybe like an abscess around their liver and we don't know why it's there, those kind of things, we're not going to take them to the observation unit. So for very simple IR procedures, we will accept them. And generally, those are not high cost procedures either, so it shouldn't be deleterious to the patient financially. Okay, so I want to talk I have a box on our exclusion criteria specifically about social, what social needs we can and cannot address in our observation units. So there is a Medicare 3 midnight rule. They have so many rules, but the 3 midnight rule states that a patient that has Medicare that requires placement in a subacute rehab or a skilled nursing facility, generally they require this 3 midnights inpatient prior to being discharged to one of these facilities. Now, in the time of COVID, this has been waived for certain for some of the patients. And so right now it might not be as much of an issue, but I expect it will go back into place. I'm hoping this is something that goes away completely because it seems a bit archaic. But for right now, we have a really big payer mix of Medicare at my institutions. So we don't accept patients in the observation unit that require subacute rehab placement if they have Medicare because of this reason. If we take them to the OBS unit, their OBS midnight doesn't count towards this inpatient stay. So it's just something to have in mind. We do take patients to the observation unit that maybe their home health aide isn't there with them. They're not quite safe to go home from the ER. So we'll hold them in the observation unit till the next day, till our social worker can come in and help make sure we can get them home safely. Or maybe they just need home physical therapy referral or Meals on Wheels or something like that to optimize them, to prevent them from coming back to the hospital, to make things better for them in that way. So there are certain social work things we can do, but placement is not one of them. I've gotten a handful of patients into subacute rehab with commercial insurance from the observation unit, but it's quite rare that we're able to do so. And then one other thing there's on our exclusion criteria, there's a box for most of the diagnoses that we see commonly, just mainly with reminders within it. So I put our anemia here as an example to remind the ED staff and the case managers that patients that we don't expect their observation stay to be 8 hours or more, we don't accept to the observation unit, because you can't actually bill for an observation facility fee unless they meet that criteria. So if they're expected to go home in the next few hours from the emergency room, we aren't going to take them to the observation unit, because that's quite a lot of work for us to do on our end when they can be discharged from the ER. So when I first started, every patient that required a blood transfusion at all was going to the observation unit, even if it was 1 unit, but we weren't getting paid for those days. So we put in a line that just says if they're an uncomplicated patient with chronic anemia that's getting 1 unit of blood, can get the blood and be discharged from the emergency room. If they're expected to need 2 units or maybe further observation because they're still bleeding a bit, we will take them to the observation unit. Unless they are requiring it's an upper GI bleed, then they need to be admitted in case they do get that endoscopy. So our exclusion criteria is meant to be, it's long, but it has everything that you need to know to determine the best disposition for that patient. All right. So if anyone wants to see our exclusion criteria, I'm gonna have my email at the end. I can send it to you just so that you have kind of more of an idea of what we have for each diagnosis. All right, so next we're going to move into the how, which is how do I measure if the observation units are functioning well? I look at a whole list of quality metrics every month, but the most important ones is I look at our average length of stay. So our average length of stay is about 16 to 18 hours. Luckily, I'm happy to say we do keep it under 24 hours. I do review if there are outliers, if there are patients that are over 48 hours, over 24 hours, then I do give direct feedback to the observation attendings, just to kind of find out, why that happened, and to also ask them, if it's something simple like a social need, maybe just the home health aide couldn't actually come till the next day, then obviously they aren't going to meet admission criteria. But if it's a patient that's like that asthmatic I mentioned earlier, transferring them inpatient would have been better for both the patient and the hospital from a financial standpoint. I look at the percentage of patients that are transferred inpatient, so going from observation and admitted to the hospital, and I'll show you in a couple of slides what that looks like. We try to reduce the hospital inpatient 30-day readmission, so I'll talk to you a little bit about that project. I review any codes or rapid responses that are in the OBS unit, and knock on wood, it's been a while. I review any bounce backs that were in the OBS unit and then come back to the OBS unit or come back and get admitted. We look at those cases and provide feedback to anywhere that we need to. And then I also provide feedback to the ED providers about the dispositions. If a patient ends up in the OBS unit that maybe should have been inpatient, then I might send them an email and have a little discussion just about our exclusion criteria, those kind of things. So this kind of open dialogue there so that the patients get the correct dispositions moving forward. All right. So this is a look at what our volume has looked like over the past 4 years. 2017 was before I took over as medical director, and then 2018 is the light orange line. And in March of 2018 is when I looked at the exclusion criteria. That's when I took over, and I said, we're excluding a lot of patients from the observation unit that we definitely can accept and should accept. So I went through and trimmed all the fat, and we were able to increase our observation census to, on average, closer to 300. So it was about 100 to 150 patients a month more on average that we were seeing in the observation unit, which was obviously a lot more work. But what that means financially for the hospital is we're decreasing the 0 to 1 day denials that we were getting for these short inpatient stays. So that's kind of where we were staying until COVID hit. And then you can see 2020, everything just tanked. And there's break in the line, and that's where the observation unit was closed. So, like I said, COVID has kind of affected everything you guys know, and we don't have enough staff on the inpatient side to staff the extra inpatient floors we made. So we have had to close the observation unit off and on over the past year. All right, and then this is a graph that just looks at the percentage of patients we transfer inpatient. The goal should be between 20 and 30%, and this is to make sure that you're not accepting patients that are too sick and that you're not accepting too few patients. So kind of that's the nationally agreed upon range that is appropriate. Ours fluctuates between the 20 and 30% line, and you can see we dipped above it, and that was last year during COVID, where just all comers to the hospital seemed to be sicker. And if you have a simple observation unit where you only accept, maybe you only take chest pain, syncope, and one other diagnosis, that's a simple observation unit. You're probably going to have a goal closer to 20%. But if you have a complex unit where you're accepting patients that have maybe more medical comorbidities and is in more complex diagnoses, up to 30% might be acceptable. So one of the bigger projects that we've worked on over the past couple of years is trying to avoid these 30-day readmissions to the hospital. As you may know, there are some, the hospital really gets dinged if they have especially certain diagnosis for readmissions like CHF. So the hospital came to us and said, we need to try to avoid these, and maybe putting patients in observation is one of the ways that we can help with this. So we worked with our case managers very closely, and then Epic was able to make a flag where if you opened a patient's chart, it says this is a potential 30-day readmission, consider observation. So we were able to increase the amount of potential admissions to the hospital, bringing them to the observation unit. And what the graph on the right shows you is the percentage of patients that were potential readmissions that came to the observation unit and were safely discharged home and did not bounce back again. So on average, it's between like 60 to 80%, but depending on the month. And the reason this range is so high is because it's really not a huge number of patients, as you can see in the graph on the left. It's about 30 patients a month on average. But every patient, I think, counts because the hospital wouldn't get paid for a lot of these readmissions anyway. All right. And lastly, just to tell you a little bit about what I do as the medical director, I sit on a couple of hospital committees. The utilization review committee is probably the one that I would be most active in. And that's because our billing and everyone else comes together and they say, look, these were the cases that were admitted to the hospital, our 0 to 1 day or 0 to 2 day admissions that were denied. And then I might ask them, can you bring me back a chart that tells me what the diagnosis codes are for these? And I can look at that information and maybe review some charts, and we can go back and update our exclusion criteria to make sure that we're optimizing the patients that are coming to the observation unit. Like I said, the readmission reduction committee, we have a role in that. And then every month, the emergency medicine department leadership and the internal medicine department leadership, we all get together just to make sure that we're working together and optimizing things across the board. There is an observation unit at most of the Mount Sinai hospitals across the system. So the medical directors, we are in close contact. We used to have a quarterly meeting, but with COVID, we haven't been doing that. But in general, we do try to streamline things and bounce ideas off each other, see what's working at one institution versus another. I work on pathway development, as I mentioned before. And then I have a big educational role. So every about month or two, we lead an observation medicine series to talk about the common observation diagnosis for the emergency medicine residents. So chest pain, TIAs, syncope, those kind of things, we talk about every other month. And then the PAs from both medicine and emergency came to me and said, we'd really love to learn this stuff too. So I also give a Zoom monthly lecture to them with similar topics. Developed a resident elective. So our residents, emergency medicine and internal medicine, neither of them rotate through the observation unit as part of their required curriculum, but I do offer an elective for them to do so with an online curriculum that goes with it. And then lastly, sometimes the hospital just comes and says, listen, we have a need. How can you help us fix it in the observation unit? So we have quite an active bariatric surgery department. So they said, listen, we have patients that get their surgery, they go home, they go to clinic for their follow-up. They're just a little dehydrated, and they wanted a way to directly I hate the word admit to obs, to place them in observation directly from the clinic. So we have this pathway now where they can go directly to observation from admitting. And then because these are bundled payments, they don't want them being admitted to the hospital because that's just not part of their bundle, and they really want to avoid that. And then the other thing was our hospital has nowhere to do dialysis after hours except the ICU. And as you guys know, not every patient that needs dialysis in the emergency room needs critical level care. So they actually went into our observation unit and they built out 2 beds that have dialysis capability now. So the observation unit is also somewhere where someone can go to get dialysis. So every once in a while they come with a specific need and we figure it out. All right, so this is a summary slide. Again, just as a reminder, the pros, observation can decrease patient length of stay, decrease cost, improve your resource utilization, streamline the care, make sure that all the patients that are coming in are getting good evidence-based care. The patients are happier and the ED hopefully has better throughput. And the cons, you don't want to overutilize your OBS unit. Don't use it for the wrong reasons because this can have negative effects financially for both the hospital and the patients. I have a reference slide here, which I can, if anyone has any specific questions, I can send you. And this is my contact information. I don't have a preference. You can use either email. And please reach out any questions at all on observation or really anything. So thank you.
Dr. Brown, I actually had a question. I think that was an awesome lecture. You know, your first graph that kind of had like the patient payment, and you know how you're kind of talking about how like sometimes chest pain doesn't get covered and the patient has to pay a little bit more out of pocket. I still am like a little confused by this and how it like actually works to come to this conclusion of the patient ending up having to pay more. Do you mind just like clarifying this a little bit more?
Yes. So what this comes down to is what you do for the patient while they're in the observation unit. So if a patient comes in with chest pain and they go and get a cardiac cath and a stent placed, that's a pretty expensive procedure. And the reason I pulled this slide back up is because that patient is getting billed for 20% of everything you do for them while they're in the observation unit. So if you do a more expensive procedure, they're going to get billed for that, in addition to the hospital fees for them being their physician fees. So it all just adds up. So that's why some stays end up being much more expensive to the patient in observation versus inpatient, because the inpatient, like I said, is billed as a bundle. So it's not based on each individual thing.
Okay.
Does that make sense?
Yeah, this actually clarified it a lot more.
Okay. I think there was one in the chat. Let me just read it. Good source about OBS documentation. Oh, yes. So the question is about the documentation. I know that I'm speaking mostly to the residents, so I didn't really want to bore you guys with the details of observation documentation and billing, but I think it's Angela. I can, if you want me to share, I have a separate OBS billing and documentation lecture that I am more than happy to share. And it goes through exactly what you need for H&P or initial note and progress notes and discharge notes and those kind of things. So Angela, send me an email. I'll send it to you.
Okay, Bonnie, you can send it to me. I'll share that with the residents. They end up involved with a lot of the documentation stuff in the unit.
Okay.
Any other questions from the audience? Is there anything else in the chat?
I don't think so.
Yeah. I was more curious, you addressed it a little bit in terms of like your responsibilities as a medical director. As an alumni, EMIM, and then I know a lot of EM grads end up going to observation medicine. What has this kind of been as kind of a career path? And in terms of like getting involved with this, is this something that you're enjoying a lot? Do you still do a lot of emergency medicine, or is it mostly administration?
Yeah, so I can give you guys a little bit about my path. And so, as you know, when I was there as a resident, I had a lot of interest. I didn't really key it down till towards the end there. And I think that probably some of the faculty members there might remember, they said, you should do OBS. And I was like, I hate that, it's boring. But you know what, it ended up being the perfect fit. And It's a perfect blend for me of the administrative side of it. And like I said, the pathway development and still having a role in education is really just, it's the perfect mix for me. And I think that it's only continuing to grow. Places that don't have OBS units now are going to need to, as long as, our healthcare system stays in its current payer structure. And yeah, it's for me, it's worked out perfectly as far as the growth along the way. When I graduated, I was hired to be the medical director of the observation unit. I didn't start out immediately, and that's just from personal issues with my family. But then I took over as soon as I was ready to. So I was hired straight out of residency as the medical director. And then last year they came to me and said, both hospitals, we want you to be the director of both sites. And so it just was a perfect natural transition for me.
Great. And do you mind sharing what's your clinical schedule?
Yeah. So when I was first hired, I was 60% emergency medicine and 40% internal medicine, which was the observation side. And I had a small portion of that was administrative starting out, which I was happy to do as a new grad. And then last year, when I took over the observation unit at Mount Sinai West, I had to, so that I can work clinically in both observation units, I really had to switch my percentage of time. So I work clinically in the emergency room 20% of the time, which is 2 to 3 shifts a month, which makes me really sad because I love working in the ER. And then the other 80% of the time is under internal medicine, and I have 30% administrative time, and the rest is clinical. So I work 3 days in the observation unit at one site and 3 days in the observation unit at the other site. So my clinical time is about 8 or 9 shifts a month, and the rest of it is administrative and teaching.
Great, thank you. And I think there was another question came up in the chat about DVT prophylaxis.
We don't do DVT prophylaxis in the observation unit. Patients are generally, not very complicated. They're mobile. So it's the 24-hour time period. And then if they're admitted to the hospital, then at that point it will be started. Because like I said, everything you do for the patient, unfortunately, is a separate thing, and medications are billed separately. So 1, they don't really need it, and 2, it's another cost. And do we accept non-mobile patients? If their baseline, the question is, do you accept patients that aren't mobile? If their baseline is bedbound, then we will accept them to the observation unit. But the period's so short that we don't do DVT prophylaxis, and I will say we've never had a bad outcome.
All right. Well, thank you so much, Bonnie. It's great having you join us virtually, and this is really great. And this is something I definitely want to continue to have some observation didactics and presentations. So maybe Dr. Brown will join us again sometime.
Of course. Happy to anytime. And yeah, and please let me go back to that last slide in case anyone didn't get my email. Reach out with anything. If you have questions, you're like, maybe I'm interested in it, please reach out. I'm happy to be a resource. So.
Great. Thanks so much, Bonnie.
You're welcome. Bye, everyone.